The following content is for entertainment and educational purposes only. It does not constitute means for diagnosis, healthcare advice, nor treatment. Make use of a qualified healthcare professional for such purposes.
Now let's talk about some of the more common diagnoses that you will be able to see. We're going to talk about more common diagnoses, and we're also going to talk about more rare forms of diagnoses. So let's talk about GAD. GAD refers to generalized anxiety disorder, and perhaps the main characteristic of this specific anxiety disorder. Remember that there are different categories, right? So there's different categories of anxiety disorders. Notice that GAD is chronic, and chronic means long-term. I don't want you to think as severe. Chronic means long-term. Acute means short-term, right? So for example, if you break your leg and you have leg pain, that would be acute because it was short-term. Whereas if you start developing pain in your leg and it lasts for a while, that will be considered chronic, right? So that's the difference. Notice that GAD is chronic. It lasts for a very long time, and if not for the entirety of your life. Notice that it's also characterized by high levels of anxiety, which means that this person is chronically anxious. This person is always anxious. Generally, it's a little bit hard to identify what the trigger is because you're simply just constantly anxious, right? It's not like we could identify that trigger easily, right? So for example, some people is, oh, if I drive, or if I get next to a car, or if I see a truck, right? So notice that we can start identifying some more specific factors. With GAD, that is a little bit more complicated because the person is always anxious. So it's really difficult to identify. Because of that, because we are unable to identify most of the time that specific aspect, we can identify that trigger. We can identify that threat. So it's a little bit difficult to address, even for treatment. Because if I can identify the trigger as your clinician, it's going to be a little bit hard to deal with this illness. And what does GAD look like? What does GAD look like? The person is immensely concerned about previous mistakes. Constant worry, constant fear about something that person's considered that, quote, they have messed up, end quote. Notice that it's also characterized by the what ifs. I like to call this the what if. What if I mess up tomorrow in my presentation? What if my parents don't want to talk to me? What if I look silly with this scarf that I'm wearing today? So notice that it's constant. It's all present most of the time. Now, let's look a little bit into perhaps the more clinical symptoms of this disorder. Notice that I always like to think about a person's behavior in three aspects, which is emotional, behavioral, and cognitive, right? Their thoughts. Notice that in regards to physical behaviors, there is a lot of trembling, muscle tension, problems with their stomachs. So for example, diarrhea, their stomach starts hurting. Notice that we started looking at a little bit more of this, that disassociation related symptoms. So the person starts having dizziness. The person may feel like they're going to faint and or in fact does faint. And notice that the individual may start sweating or have heart palpitations. This is generally how I like to start whenever I'm trying to diagnose or provide, I should say, a diagnostic impression, because for a lot of people, it's really hard for them to identify what they're thinking, even though it's their own thoughts. So for a lot of people, so how does that look like? Or what are you feeling? And it's hard for them. And I'll say, okay, what does it look like? For example, do you start shaking? Do you start sweating? Well, that's a little bit easier for most to identify. Oh yeah, I start shaking, or I think I'm gonna throw up, or describing the physical symptoms is usually easier for the person, and then we can move on to other symptoms, so emotion and cognition. So any questions about that? Good deal. Let's talk a little bit more about specific illnesses, right? Let's talk about more specific illnesses. So remember, these are all categories of the category of anxiety-related disorders. So let's talk about specific phobias, right? Specific phobias are generally an irrational fear, right? So whenever you hear anxiety, whenever you hear the terms phobias, notice that that is related by an irrational or perhaps ill-founded fear, right? Generally with a specific phobia, the fear is irrational towards, say, for example, a specific object or situation. And it is irrational because generally it offers no realistic danger, right? That's why it's considered an aspect of phobia and or anxiety, because you're not in danger. It's not a realistic danger. So for example, some of the ones that we will see often is, say the individual is immensely scared of getting into an elevator. Well, technically speaking, that elevator can't hurt you, right? So the fear that we're having is irrational. And I'm not saying that fear by itself is irrational, because notice you actually need fear to survive, right? If you guys had no fear, you wouldn't survive. It would be impossible. Fear is an evolutionary trait that we share with other species, because if it wasn't because of fear and pain, you wouldn't survive. So for example, how many of you have seen that series, Psychopaths? Anybody has seen that series? All right, so that series is categorized by people who have lost fear. They simply don't fear most things. So there's a really interesting scene in that series in which there's a person who is literally committing a crime. This person's literally murdering someone in front of just the people who are just walking down the street. And they don't experience any fear. They're like looking at us, oh, well, that's interesting. And they just keep walking. Notice that the problem with that is that they don't have rational fear. That would be something that could help you survive. Whereas anxiety does not help you survive because it's considered irrational. Quite the contrary. It stops you from doing the things that you want to do. So in that specific case, the rational thing to do, oh man, I'm witnessing a crime. I need to go this way, right? But whereas the person with anxiety would stop them from doing things that they would want to do. Let's talk a little bit more about panic disorders. The difference with a panic disorder is that it's categorized by an immensely overwhelming surge of anxiety, right? It is a very intense, generally it's seen as sudden and unexpected. Part of treatment is to make this expected, right? See it coming before it actually happens. Notice that is basically overwhelming anxiety. Basically, if you're always chill, that would be a 0. 10 would be a panic attack, right? It's an overwhelming surge of anxiety. Another interesting aspect of disorders is agoraphobia. And this one is particularly characterized with going to public places. Now, for some individuals, for example, individuals who have PTSD, like trauma-related disorder, notice that they may have some of these symptoms, right? So which is why it's so difficult to diagnose individuals, because some of the symptoms are present in, the same symptoms can be present in a wide variety of disorders. So say, for example, an individual who has suffered from PTSD, they might feel uncomfortable, and that little term that we talked about, distress in going to places, but not because of anxiety, but because of the fear of reliving certain triggers for their trauma. Notice that OCD, also referred to as obsessive compulsive disorder, generally in this specific case, the characteristics are seen as a person who must engage in obsessions, who must engage in compulsions, right? So compulsions, I should say, being categorized as I must do this. It is a need that I have right now, and I have to do it, right? Because if I don't do it, this is going to cause a significant amount of distress. So I had a client who older gentleman. He was in his 60s, and he could not leave his house. He could not do it if he didn't turn the switch on and off a couple times. I think it was like 5 or 10 times before he left. So if you were to stop him at flipping the switch in the 4th time, that would cause immense anxiety, right? So that's what OCD is characterized by. A lot of individuals, oh, OCD is someone who's worried about bacteria. It's generally any habitual behavior that is categorized as compulsive, right? So something that you must do because if you don't do it, it's going to cause a severe level of stress. I also had another client who had to count and look at the corners of buildings, and he was an engineer, by the way, so he had to look at the corners and start trying to measuring the angles of the corners and see if everything was aligned with each other. Because if he wasn't allowed to do that, it would cause him severe distress. So notice that could also be considered as it could be a characteristic of obsessive compulsive disorder. A lot of people like to think, oh, well, it's because the person is an engineer. If it causes distress, then this is characteristic of a mental illness. It's not because of his job. Now, the last thing that I would like to talk about is post-traumatic stress disorder. Notice that the individual is going to start feeling distress. The person is going to start feeling a disturbance, particularly geared towards a major traumatic event, How do we categorize something as majorly traumatic, particularly related to PTSD? Basically, it could be in many methods. So it could be within 3 aspects. So for example, there was a real threat to this person's life or safety. So for example, a car accident, right? You get in a car accident, that is a very viable threat to your life. A kidnapping, being attacked at war, surviving a shooting, right? Surviving a sexual assault, right? These are things that could have taken your life and you still survived them. So that would be the first method, which is you yourself almost died or could have died because of a specific event. The second thing is witnessing the severe threat of life. So for example, people who were in say, for example, a school shooting, right? So they survived it and they weren't shot at, other people were shot at, but they survived it, right? They witnessed it. So because they witnessed a severe aspect of threat to life, then these people could also be considered a person who has been exposed and could potentially have PTSD. And the third method that perhaps an individual could be exposed to this type of danger is because it's part of their job. Right? It is part of their job to deal with death or deal with perceived situations where it could have been potentially deadly. So for example, police officers, EMTs, people who work in the military, say for example, picking up bodies or having to look at bodies every day that are mangled and tangled. Or nurses, medical staff, ER staff, these individuals, even though their life wasn't in danger and they didn't witness the danger occurring, they are still, because of their job, every day they are exposed to a factor of danger. So notice that those are 3 potential ways in which an individual can experience a major traumatic event. So any questions about that? Good deal. Let's look at etiology. Remember, every time we see this term, I want you to think about cause or that history that could have led to anxiety-related disturbances. First off, we always want to look into biological factors, right? As you know, we like to look at the biological factors first. And actually, that's what a good clinician would do. We want to rule out anything physical before we actually start looking at the mental health side. So that's one of the things a good clinician would do. Hey, have you been seen by a physician about this? Because if you haven't, maybe do that first and then come back, right? So what could happen? What could happen with biological factors? So for example, chances are if you have a sibling, particularly a twin, right? Or other relatives that have that specific mental illness, that does increase the chances that you will also have that mental illness. That's particularly too with schizophrenia, by the way. It does have a high heritability factor. Now, another aspect is that particularly with anxiety disorders, notice that early in our lectures when we first met, notice that we talked a lot about brain neurochemical activity. So the electricity triggered in your brain based on neurotransmitters and your brain chemicals. So there is a significant relationship. There is a relationship link between neurochemical activity and your potential manifestation of anxiety disorders. Now, we looked into the conditional factors. Let's look into the environmental factors. So for example, conditioning and learning. You and I have had talked, we have had immensely long chats about conditioning before. Notice that your anxiety response can simply be related because of classical conditioning, which means something, or also I should mention operant conditioning. So what does that mean? It means that because you have been exposed to a relationship linking things that weren't necessarily linked together, that were inherently dangerous. For example, some of you, right, if you were to see a 18-wheeler, right, an 18-wheeler, and every time you see an 18-wheeler, it just causes you severe anxiety. Well, the 18-wheeler is an 18-wheeler. That truck cannot hurt you. That truck is just there. That truck is not actively trying to hurt you. But notice that at some point you might have linked that with a source of danger, right? So for example, say your uncle or your dad on an 18-wheeler, and every time he wanted to scare you, you just honk the horn really loud to scare you. So now every time you see an 18-wheeler, even though you may not call it, you used to be scared to death every time that person would try to blow that horn. So notice that inherently the truck can't hurt you. The truck is just there, but we have associated the fear and the anxiety that this truck may produce in regards to your expression of anxiety due to an unrelated, non-threatening factor that now you have associated as threatening. Any questions about that? And lastly, one characteristic is that notice that some individuals may just simply be inclined to be scared more easily than others. Right? Some individuals are simply more scared than others. Let's think about cognitive factors. Let's think about cognitive factors. Notice that your way of thinking can lead you to be more vulnerable to anxiety disorders. Notice that in regards to your capability, let's compare you with someone who is non-anxious. If I were to present you with something that could be considered threatening, and I were to ask you, is this threatening or not? Notice that a person who has anxiety will more frequently report that that aspect is threatening versus compared to a person who is not anxious or has not been diagnosed with an anxiety-related disorder. So notice that your way of thinking in it by itself could be leading to your experiences of anxiety. This is immensely important because this is particularly what I use in therapy most of the time, right? Your way of thinking can be distorted because remember, your fear is irrational. So we're trying to make it rational. Let's analyze, let's look into this fear as a means to reduce your interpretation of it being anxiety producing or threatening. So notice that I may utilize those types of therapeutic skills to address this misinterpretation. Because generally the things that cause anxiety are actually not threatening. Generally they are not threatening. And if they are threatening, they are being exacerbated because of your way of thinking. It might be exaggerated, right? So for example, oh, an 18-wheeler can't kill me. Sure it can. It can't just be driving at a certain speed and run me over. Is that possible? Sure. Is it probable? No. What is more probable is because of your anxiety, you're going to have an accident. That will be more probable. Notice that another aspect of thinking and how it impacts your anxiety is that you have too much attention. You're paying too much attention to perceived threats. So not only are you misinterpreting what could be threatening, you're also doing it all the time. You're also excessively thinking about what could be threatening. Can an 18-wheeler run me over? I mean, it can, but how much are you thinking about this 18-wheeler running you over? compared to the average normal individual, right? So I'm sure the average person has thought about, oh, that 18-wheeler is going kind of fast. But is it a persistent, excessive thought that they're paying attention to? Or is it rather that this is consuming a lot of your time? Notice that another thing is that your pattern of thinking can also be distorted because you're only selectively recalling things that seem threatening, right? Things that seem threatening. So for example, you may say, well, the other day I was in the interstate and this 18-wheeler just drove past me, right? Like someone who was not paying attention. That was so scary. That was one 18-wheeler out of the 150 that you saw during your trip. You saw 150 18-wheelers during your trip throughout the interstate. So you're selectively recalling the one that was threatening versus the 150 that drove past you that were not threatening, that were doing the speed limit, that were driving correctly, putting their turn signals and things like that. So notice that now you are putting selective attention on what is it that you want to recall. And part of therapy is to change these three aspects. It's to turn the irrational into rational, right? And that can actually lead to a decrease in your anxiety. Yeah, there was this truck that was driving super fast. What about the other 150 that were not threatening to you in any way? Oh, I didn't think about that. That's part of therapy, is to confront the irrational or misinterpreted ideas. Any questions about cognitive factors as to how they would relate to anxiety? Good deal. Notice that the last factor that could contribute to anxiety is stress. Notice that if you are undergoing high levels of stress, that can lead to an increase of precipitation or aggravate the actual anxiety disorder. So if you already have anxiety and you're going through a lot of stress, notice that that can lead to a worse symptomatic expression of your anxiety. So any questions about that? Good deal. All right. Notice that in regards to the dissociative disorders, this is when an individual loses contact to their consciousness and memory. You have lost contact with what your consciousness is and your ability to recall consciously your memories. And this happens to such an extent that you lose your sense of identity. Quite literally, you lose your sense of identity because you have lost contact with your consciousness. So if you recall from previous lectures, we talked about your states of awareness, right? The conscious, the subconscious, the preconscious, and the unconsciousness. So a person who has dissociative disorders has indeed lost touch with their identity. Now, there are different types of dissociative disorders. Let's talk a little bit more about dissociative amnesia. In this specific regard, notice that the individual loses contact, and that link with their personal information, right? Their identity. I do want to point out that this is not normal forgetting. If you were to ask me what the name of my 5th grade teacher was, I won't be likely to remember. I do think it was like Smith or something. It was like a super common last name. But notice that it's not because of normal forgetting. And it is not because of a biological aspect. So for example, the person got in a car accident, now they can't remember who they are. Or maybe they have a brain tumor. It's not categorized by a physical trauma or illness. Notice that in this specific regard, it tends to be immensely sudden. Today, I know who I am, Dr. Shar, I'm from home, right? I teach university, I work private practice under supervision, and then tomorrow I wake up not knowing who I am or who anybody in my surroundings is. Generally, because it's not attributed to any physical aspects, is generally attributed to excessive stress. Basically, your brain has reached the point where I need a break, I need to shut down. The person has an inability to recall aspects of who they are or those around them. Any questions about that? Good deal. Let's talk about one that most of you have heard about before. DID, also known as dissociative identity disorder here in the United States. Other countries still refer to it as multiple personality disorder. We do not refer to it as that anymore, just as we don't refer to Asperger's as Asperger's. We refer to Asperger's as autism, just like we refer to what we used to call mental retardation as learning disability. So we do not refer to in America specifically, and I think some other countries do it too, but not everybody does. We don't refer to it as multiple personality disorder. We refer to it as dissociative identity disorder. Notice that this specific disorder is characterized by a disruption of identity. Generally, we have two or more completely and very different personalities. Notice that this disorder remains to this day as one that is controversial because in regards to the etiology, causes of this disorder, we're still conducting research about it, right? We're still having to conduct research about it. Now, what it is commonly considered as the etiology of DID, formerly known as multiple personality disorders, is generally severe trauma. I mean, severe trauma, particularly that occurred during early childhood. So that is the general concept that we have about DID as of today. That doesn't mean it won't change. That doesn't mean, because that's a good thing about science, right? Is that it gets revised with more evidence and data that we get, the more revisions that we can do. And I do want to show you an illustration of a woman who has not only DID, which is already a severe, very severe mental illness, but she has a severe case of a severe mental illness. If you want to know how common DID is, you would think it's super common because that's what we always talk about in the media and on YouTube, and it's actually immensely rare. It's a very, very rare mental illness. So in my current place of work, we have about maybe 700 clients, and only 2 of them have DID. One of them has a more mild form, and one of them has a little bit more of a moderate case of DID. So it is rare. It's not as common as you would think. But again, it's usually caused, and I should say caused because of a severe exposure to trauma. Generally, the consensus as of right now is that you've had to split into other personalities because whatever happened that was traumatic is too much to cope. So in order for you to preserve this, the person that you are, the concept of the self, you've had to, your brain has actually split the identity so that it doesn't hurt that idea of the self. I do want to show you an illustration of such case, a immensely severe case of DID. The person is not American, so they may use terms like multiple personality disorder, because again, that's not the term that we use here. But I do want to show you a severe case of a severe mental illness. So in this specific case, we are going to view a woman who underwent a lot of trauma. If it's related to incest and sexual trauma, sexual abuse, so if this is not something that you want to hear about, you're more than welcome to wear your headphones, to step out of the classroom, because it is an intense space. So your mental health is always the most important factor. So any questions about that illustration? Yes, sir. So the question for those of you who couldn't hear is, how is it that we distinguish aspects of the person malingering? So for example, faking good or faking bad. So the formal term for that is malingering. So malingering is a person can pretend to have symptoms that they actually don't have, or that they are much more severe, or vice versa. They can pretend that they don't have any symptoms, or that they're actually much less severe than what they actually are. A lot of the things that we do for diagnoses are statistical, right? So a lot of the diagnoses that we do, they will have, say, for example, instruments that are standardized and validated. So we can statistically conduct a correlation to see whether or not this person is actually malingering, right? So we do have statistical analyses through assessment, right? So for example, we can conduct assessments with an individual to determine whether or not is this person malingering, or is this person prone to malingering, and whether it be faking good or faking bad. So that's one of the techniques that we use. We do use statistical analysis built in assessments to understand whether or not a person is malingering. Now, remember that correlations are not causation. So just because something is linked, it doesn't mean that it is indeed true, right? That there is a link. But we do have built-in scales for malingering in most assessments to determine whether or not an individual is indeed lying. Another method that we can use is what we call inter-rater validity. That is a statistical analysis in which what we do, we will have multiple raters, right? So for example, multiple clinicians, right? We'll have multiple psychologists, multiple psychiatrists, or people who are trained in the field, and they will do an assessment with this individual. And basically what we do is a statistical analysis between their rates of agreement, right? So for example, how much do these, usually it's done with at least 2 people. The more people, the better, because we can provide a better statistical analysis when we have more variables to regress to. So that's another way we can find out statistically whether or not this clinician, this clinician, this clinician agree with in terms of the assessment. Also clinical judgment, right? Part of it is you can conduct statistical analysis for malingering, you can conduct statistical analysis for inter-rater validity, and you can also use clinical judgment. For example, in your clinical judgment, is this truly related to the DSM, to the Diagnostic Statistical Manual of Mental Disorders here in America, or is it not related to that disorder? So those are only 3 methods. There's many methods that we can utilize to distinguish whether or not a person is malingering or not. Does that answer your question? Okay, good deal. So as you can see in the case of the video that we just saw, this woman unfortunately was sexually abused very, very harshly by her father. If you wanted to know what happened during the video, she was getting ready to testify against her father. Notice that her earliest personality is 4 years old, which is when the sexual abuse started with her father. Her father would sexually assault her with instruments, with his own body, in a shed that they had in the back so that nobody else could hear her. And no police officer ever believed her because she was mentally ill, until one detective did. And he actually conducted the investigation interrogation. It was taken to trial and he was found guilty. And I think he was given 45 or 50 years in prison because of the sexual assault that he had done towards his daughter. So it is a very unfortunate case, but at least there was a resolution. So any questions about that? Yes, sir. She still has, so her name's Jenny, right? So her actual name is Jenny, and she was talking about muscles, she was talking about Judas, she was talking about symphony. And notice that people who have DID will generally have like their main personality, which in her case was Jenny. So when we're thinking about learning, notice that technically speaking, she will learn, right, from school, right? She will learn from school. But notice that their personalities are not there for learning. Those personalities are to compartmentalize her trauma. So for example, Symphony is the one that knows everything that happened. She's the one that's going to testify. Judas, on the other hand, he's the one that tells things as they are, right? And then Muscles is the one that has the more strong aspect of behavior. They're not there for learning, right? They're not there to learn. They're there to basically cope with the severe trauma that she had. So I would say no, because that's not what they're there for. They would be aware or may not, because some personalities are not aware of each other. And for some patients, they are aware of each other and they share like a common consciousness, if you will. But for some patients, that's not the case. So it could be either way. Could be either